webinar today. This is session 6 of 10. Can't believe it's going this fast. And we're offering, like I said, nursing contact hours after each of these 10 sessions. As you know, they are also being recorded and they are available on our Mountain Pacific website. So thank you for watching those and sending them off to your staff and other people you feel that may benefit from watching these presentations, because Dr. Reza and Dr. Eric do a phenomenal job. So this next session will be on February 10th at 3 p.m. and it'll be on managing behavioral health emergencies in nursing homes. There will be polling questions today, and you saw the first one was just me asking what your credentials are, as well as we will have an evaluation, and that will be placed in chat towards the end of the webinar. So, and if you don't get a chance, or if you did not receive a nursing contact hour from previous sessions, please just email me, and I'll put my email in chat here in just a few minutes. You will have the ability to unmute yourself, but please keep yourself muted while the presenters are speaking. But if you have questions, please come off mute and just go ahead and speak. I know Dr. Gomi and Dr. Arzubi appreciate the interactiveness and being able to ask questions and comments and things like that. So when people are talking, sometimes it gets distracting if someone's not on mute. So just pay attention to that. We'll also have time for question and answers after Dr. Reza's presentation. But again, take yourself off mute, or you can place those questions or comments in the chat. So after I introduce the speakers, they'll recap what was discussed during the last session, which was on January 13th. And then we'll start with this week's topic of behavioral emergencies. So let me introduce. So Dr. Eric Arzubi, he co-founded Frontier Psychiatry in 2019 and introduced an accelerated, more aggressive response to Montana's growing mental health crisis. He served as chair of psychiatry at the Billings Clinic for 5 years, during which time he led the creation of Montana's first psychiatry residency program and Montana's first empath unit for emergency psychiatric care. Before moving to Montana in 2013, Dr. Arzubi spent 10 years at the Yale School of Medicine, where he earned his MD and completed postgraduate training in general psychiatry and child adolescent psychiatry. And so then Dr. Reza Gomi holds a BS in computer engineering from Rensselaer Polytechnic Institute, an MSc in biomedical engineering from Johns Hopkins University, and an MD from University of Massachusetts. So he's been a little busy. He completed a residency in psychiatry and a fellowship in movement disorders and behavioral neurology at the University of Washington. He currently practices neuropsychiatry with a focus on cognitive, memory, and movement disorders. He is also active in engineering and clinic research, focusing on using advanced technology, such as using voice recognition to track and monitor treatment of neuropsychiatry. Sorry, apparently my my Alexa thinks it needs to have some input here. Focusing on voice recognition to track and monitor treatment of neuropsychiatric diseases such as depression, schizophrenia, Alzheimer's, and Parkinson's disease. So thank you both, and I'll open it up to you, Dr. Gomi.
Cool beans. I'm going to share screen. Let me share my slides for everybody. All righty. That's I'm always switching between Mac and Windows, so I'm always, there we go. Hi everyone. As you know my reputation, I will be enforcing lots of fun participation during the talk. So you may or may not regret joining us today. Hopefully it's the former, or the latter, I should say. So TikTok 6. So we've been wanting to talk, it's supposed to say professional. I love that I never update the front slide. It's always the one from the previous week. So delirium is very, very closely tied in with today's topic, which is preventing behavioral emergencies. And we'll define behavioral emergencies, but thinking about times when a resident or a patient's behavior becomes a threat or risk, and basically how to prevent even getting to that point, so we don't have to, basically for lots of reasons, we don't want to get to that point, right? We don't want to have to use medications or restraints or anything else. We want people to be comfortable and happy and not even get to that point. So we're going to talk about that today. We're going to do a little bit of review before we start. Just my weekly disclosures. Nothing's changed over the course of giving these talks, but of course I work with Frontier Psychiatry, and then I also work with Brain Check, which is a cognitive testing company, part-time. Frontier is, trust me, taking up most of my time. So just a recap of the series, like Alona mentioned, we're already at session 6. It is flying by. And so we're really trying to focus on this session, the last session, this and the next, these 3, really focusing on some practical ways to address challenging or risky symptoms or behavior that we witness and have to treat ourselves and intervene. All of us have been here. We've all witnessed it. We will all witness it again. They're very common things. So we're really trying to drive the point here. And so today we'll try to focus a little bit more on prevention, but it's really along the theme of how to treat those people we work with that have cognitive changes in delirium. So just to recap, all the way back now, harder and harder to remember each week. Why are we doing this? Why are we talking about trauma-informed care? And how is it tied into all of what we've been doing with dementia, with delirium, with behavioral emergencies? We all have to pause and remember that we're all subject to the environment and where we come from. And that environment will inform our behavior as young adults, as children, as older adults, once we enter old age. And so even in those kind of hardest moments when we see somebody behaving in a way or acting in a way that is very hard to understand, always good to pause and think about there very well may have been some trauma behind it. And trauma has a wide definition. Dr. Arzoubi in his first talk touched on the ACEs ongoing humongous study, but adverse childhood experiences. And we've learned a lot from these series of studies, including thinking about trauma in several different forms, not just the easy to sort of think of traditional forms of physical or emotional abuse, but also all that household dysfunction. And people genetically have different resilience levels. And so something that might not be considered to you trauma could be to someone else. So it's important to just keep an open mind and remember that trauma takes many different forms, and that those adverse childhood experiences go on to impact someone's longevity, how long they live, how well they live, right? Their depression, anxiety, PTSD risk, their medical risks for cancer and diabetes, their substance use risk, alcohol and drugs. So it has endless impacts, and it's with you for the rest of your life. And a lot of what we're talking about today is how to help people cope with that and still live a high quality life. Why are we, the real world example that we're talking about is, we talked about in session 2, was some of the work we did at Lewistown. Just to recap, this was an example of a quality improvement study. We're mentioning this because it's meant to motivate and just inspire you to think about doing this in your own facility. We did a very straightforward, we were lucky we had support from leadership, but we did a relatively straightforward study where we brought in telepsychiatry, so virtual care to the residents in this facility. And we found that not only did it go over well with the residents and the caregivers, the staff, generally satisfaction was higher than average. We found that we were able to achieve focus on patient autonomy and independence, and really trying to focus on what a patient would like. And so we were able to reduce number of psychotropic medications and really try to help increase the number of gradual dose reductions. With some patients, and this is a facility that has some very severely ill people, and I mean medically ill, a very wide range of illnesses. So sometimes we have to use a proxy for, sometimes I can't ask a patient, or they're not able to answer very clearly what exactly it is they would like. So some of these are proxies, like reducing number of psychotropic medications. We think of that as a proxy for patient autonomy. We want them to be on as few medications as possible. And then as a dementia specialist that thinks about cognition, I'm always worried about side effects and impairing people's cognition. So keep in mind, sometimes the goals or what you might want to do in your facility might not be as direct or as easy as saying, well, we took a poll of our patients and this is what they want. they want more chocolate milk in the fridge. You know, it's not always that easy. So sometimes you have to really sit back and think about what might be beneficial. And so in the third talk of the series, we talked about loneliness in nursing homes. We talked about the impact of isolation on health. We pointed out there's quite a bit of data out there now that demonstrates that loneliness and isolation have amazing impact on health, much more even than I realized before I looked at the data. It's kind of shocking, but in that graph in the lower right hand of your screen, you can see that social connection, social versus high versus low social support. There were various measures in this study of how to measure social support, but you can see some of those factors outweighed even smoking fewer than 15 cigarettes a day, smoking cessation, physical activity, obesity, air pollution, all those things. They actually conferred a greater risk on longevity and life expectancy than even some of those traditionally focused measures, such as smoking and weight and physical activity. So we really can't overstate the importance of loneliness. And one thing we also did was we spent time talking about what to do, what can we all do in the facilities that we work in. And so some things are much simpler than you might think, even just, especially during COVID, what do we do? But helping people have visits through the window, having people, families sending cards and letters. Remember, a lot of what we talk about has to do with recruiting help, having family support staff or volunteers in the community help out. This is not meant to be, these are all things you should do as somebody working in this facility, but we all have to feel comfortable asking for help. And especially more than ever with COVID, we could really use the help of having video calls, even online services, having a patient log into an online service, whether that's a religious service or a group with Alzheimer's Association. These are all kinds of things that will help feel. It's not going to be perfect. I mean, it's, nothing's perfect, a replacement for being in person, but certainly being on a video with somebody helps reduce that feeling of loneliness, which can be really beneficial to someone's longevity. Excuse me. So we also then jumped into session 4, which we talked about dementia. And this is really my area of focus clinically. I spend the vast majority of my time focusing on how to help people with cognitive decline, which is most likely due to neurodegeneration. We talked about the importance of remembering that dementia is an umbrella term. Many of our patients carry this diagnosis, I should say, or label in their chart or in their record. But what we're trying to do systemically is help identify specific causes of the dementia and help patients and families and caregivers and staff better understand what's driving that neurodegeneration, what's driving that cognitive change. Also to help prevent and reverse those causes that can be. So we don't want to miss, a low vitamin B12 level or a hypothyroid, something like that. So keep in mind, just as a recap, so dementia is an umbrella term. It's not a why, it's just a how are they doing? So if someone has 2 or more areas of functional impairment, they're getting lost while driving, they can't navigate, 3 dimensions. They're also forgetting to pay their bills. So they have somebody helping with that. And granted, that's not because of other things, they're not obviously sitting in the hospital with a broken leg. I mean, so with medical things kind of ruled out, that would qualify you for the diagnosis of dementia. Now, why is that happening? That's another story, right? We have to look at, is it Alzheimer's? Is it frontotemporal dementia? Is it Lewy body dementia? And that's something for the medical specialist to figure out. That's something I do. I get referrals from neurology and psychiatry and primary care. But even just getting to the point of being able to sort through with confidence that it's likely neurodegenerative, it's likely one of those, that's still very helpful for a patient, for future planning. So what we talked about a lot in that talk was the importance of trying to give someone as well characterized of a diagnosis as possible. And just to reiterate, some causes of dementia or some symptoms of dementia are potentially reversible. I've had Many patients now over the years reverse cognitive decline at an older age when it was thought to be because of dementia by getting a CPAP because they had sleep apnea that was untreated, or treating that anxiety or that significant depression. There's lots of masking depression causes. So want to be very vigilant of that. And I bring this up because this is not just for primary care. This is for all of us to be vigilant of, whether we're a social worker or a caregiver, or whether we're mental health staff. These are things that you actually have more insight to than many of the physicians or the providers, the frontline providers, even nurse practitioners and PAs, because we don't get to spend that much time with patients. So if you're in a facility and you get to know someone, you're in a position that you'll be able to say, you know what, I think there's something else going on here, and that information is invaluable. And as a provider myself, I can't do my job without that information. I wanted to just drive this point home. I think this is really helpful for patients. I often will have patients that are maybe even 100 years old and their cognition's totally fine, but they say, man, I can't move as quickly as I used to. I can't add things up in my head as fast as I used to, or I can't drive as well as at night. Those are all things that are normal parts of aging. And what's fun about this is, you can kind of see, and again, this is not, although the curves, some of them look like they're going really far down, they're changing within the normal range. So none of these are representing dementia. The blue diamonds, for example, that spatial orientation, that naturally drops a few percentiles, with age, but it's never supposed to be to a degree that you can't drive or navigate or get to where you need to be. You just may need to pay more attention. You may need to try harder. You might be complaining that, I used to be able to listen to the radio and do this at the same time. Why can't I do that? That's not a dementia, that's normal aging. Now, verbal ability, verbal memory, numeric ability overall, while they may be a little bit slower, your verbal ability should still be stronger. In fact, you can see some things are peaking in their 50s and 60s. So for my ongoing joke with this is, many of us in the audience have a lot to still look forward to. It's not all downhill from here. So progression of neurodegenerative disease, really trying to reinforce this thinking here. This helps with our approach to patients that we work with in our facilities, is just remember that over time, the way we're understanding dementia now is that over many years, usually 10, 20, even 30 years, there's a gradual accumulation of neuropathology, and it will be accumulating, and won't show signs until it reaches a certain amount in the brain, at which point you start tripping up with that driving, with the burning things on the stove, with the remembering to pay your bills or forgetting people's names. And that's when that cognitive decline is really visible. And when those kind of reach this significant intersection, that's when we call it dementia. When that burden of neuropathology reaches a point that you're affected in those two or more areas in functioning. And so there's a long pre-symptomatic and even prodromal stage. And people, keep in mind, a lot of people are in this prodromal, which we call mild cognitive impairment, where if I really drill them in a test, I will find a deficit. I can probably measure it. But in day-to-day, most people, unless maybe it's their partner that sees them all the time, most people wouldn't even notice that there's something wrong. So this is another reason to think about how you might be picking up on new onset neurodegeneration in those residents and staff and patients that you work with as a staff member, because there might be a patient that came to you because of another issue, whether it was multiple sclerosis or a stroke, but then you've been watching them slowly decline over time, and you've kind of witnessed that yourself, and now you're almost watching them go from prodromal mild cognitive impairment now transitioning into dementia. And that's a very important thing to note and to also share with the providers. And so early detection, this is also some things to be optimistic about. We've come a long way with detection, and that's leading to new treatments. But keep in mind that we have a number of tests now that can detect those changes biologically much earlier in life. So I just want to point out, traditionally we were relying on this purple line, which is a clinical function, And oftentimes by then there's too much neuropathology accumulation in the brain. And we say, oh, it's too late to do anything. Not true, but tempting to say that. Now, the earlier we detect it, the more we can do. So we go back to MRI, there's PET scans, and there's even tests to do with your spinal fluid that can detect things. Even some of this can be decades before. So obviously, if you don't have any issues, there's no reason to do that early, but these tests can be very sensitive early on. And the cheaper and easier these tests get, the more we'll be able to use them as screening rather than needing to use this purely as a diagnostic. And this is very tied into preventing behavioral emergencies, the topic of today's session, because dementia is one of the largest drivers of behavioral emergencies. So keeping in mind that having a patient accurately labeled with their cognitive status is already the first step to preventing a behavioral emergency. So just knowing that somebody has cognitive decline, that there's a concern for neurodegeneration under that decline, that's already giving you perspective and ability to prevent a behavioral emergency. We'll talk more about that. Obviously I'm very biased. This is what I do for a living, but I can't overstate the importance of diagnosing and making sure the diagnosis is correct. So I find it's very rewarding. My patients are generally very appreciative. Families are appreciative. I work with a multidisciplinary team, which is incredibly rewarding. And also you really can't do this without a multidisciplinary team. And so patients now have the door open to plan for the future. Their families can plan. We also have a number of treatments I had mentioned that are coming along. And then really, I'm going to keep hammering this every session is, my big soapbox is try to, when you're clinically describing a patient, I like to describe them thinking about syndrome, stage, and neuropathology. So all of us can talk about stage. We're all qualified to talk about stage. Do they think something's wrong, but you're absolutely sure nothing's wrong. The screening tests are all clean. So it's a subjective cognitive, impairment. That's the SCD here, subjective cognitive decline. Or is it mild cognitive impairment? They have test impairment, their MoCA score is low, their MMSE is a little bit low, but you know what? They're living independently. They're able to get from A to B. There haven't been any major issues. Or now they're bumping into things in their car. They haven't been returning their calls. They've been missing payments. That's dementia. We are all capable of providing some of this assessment here and using the stage. So I really want everyone here to really practice doing this with patients and really trying to help characterize, where are they in terms of their cognitive function. And then you can work with the providers, such as myself, to really figure out what's syndrome. Okay, well, mostly they're having trouble with short-term memory, or actually their memory's fine, but they're bumping into a lot of stuff visually, or they just seem to be really confused about the day and time, but their memory is somehow okay. So that's a syndrome. That's starting to describe it. We're all able to start doing that. And then the neuropathology is where the tests come in, and that's really giving you the biological answer. But I really want to just drive the point home that syndrome and stage, I think we should all be thinking about. This is not just a thing for, medical providers or doctors.
Hey, Reza.
Yeah.
Oh, yeah. Sorry. No, yeah. I think we're both doing the same thing. Just to learn, there's a question in the chat wondering why so many people in long-term care facilities kind of have a blanket diagnosis of dementia rather than a more specific differential or even more nuanced diagnosis.
Sorry. Yeah, absolutely. So that's exactly why I do the work I do. So that is the most common when we look across America right now. 5 to 7 million people with Alzheimer's disease. Far less than half of them, much smaller percentage, have the actual diagnosis. And part of that is the culture of shifting. There's a lot of concern, I think, there's a few things. There's concern about stigma. I think a lot of people are scared to diagnose dementia. It's a big deal. And not having like a very clear test that tells you, it's easier to diagnose cancer when we have that microscope and, and you look at it and you say, okay, there it is. I'm pointing to it. It's a lot harder to point to things in the brain, although we are getting much better at it. And so for the primary care provider out there, it's really above and beyond what their training and their understanding is at this point. And so that's where I'm trying to figure out how to make myself much more accessible in terms of like spread my brain, you know, all over, because it is hard to give a clear diagnosis. So I think there's a lot of resistance, there's a lot of concern, but on the other side of it, people do tend to be really appreciative. I think it's hard to pull a trigger on a diagnosis that's so significant when there's always going to be some kind of doubt. You know, we can never be 100% sure. So I think in long-term care facilities, the focus really shifts to the patient's day-to-day and how they're doing and how to support them. And so the kind of focus can kind of leave what the actual diagnosis is. Thanks. Yeah, thanks for pointing that out. Yeah, I don't always see the chat, so thanks for pointing that out. So just this Lancet Commission, which they just actually updated in 2020, I'd like to point out, this is also a way to educate patients and mobilize them, give them some empowerment, that there are quite a few modifiable risk factors in the Lancet. They actually, this rate actually went up from 2016 or 17 when they last did this commission. The potentially modifiable factors you'll see down here, 40%. So they're thinking 40% of dementias are actually either preventable or modifiable. That leaks right into behavioral emergencies. So if we address these things, we directly prevent behavioral emergencies, because we know the number one driver of a behavioral issue in a facility is cognitive impairment. That's the number one driver. And so smoking, if they're on and off nicotine is a stimulant. It is nothing wrong with nicotine by itself necessarily at certain doses, but smoking has a lot of other things associated with it, right? All that junk in cigarettes, that can cause confusion if you're already much older. If you have COPD, those are all things that can cause cognitive impairment. Depression, social isolation we talked about, inactivity, air pollution, these are all things that are going to add a layer of confusion. And if we are addressing these, that's a large percentage of behavioral issues that we're going to prevent by preventing sudden changes in someone who already has cognitive impairment. And you can see obesity up here, alcohol, hypertension, traumatic brain injury, hearing loss. These are all things that are modifiable earlier and later in life. Hearing loss, especially with a lot of patients, they may be having a behavioral issue. You might be getting frustrated with them, and it turns out your hearing aids aren't on, or they're not in, or they're not adjusted correctly. That can cause a lot of irritation for somebody who has a cognitive difficulty already. So what I wanted to be thinking about is these all help us immediately and help the patient long term, because what we're trying to do is keep them safe in the facility. And so some of the things we talked about, this finger study is quoted a lot. I bring it up all the time. It was just a really good study, just demonstrate the impact that things as simple as hard as nutritional guidance, exercise, cognitive training can actually have a huge impact on people with dementia, with an actual neurodegenerative disorder. So it's absolutely not hopeless. That's my repeated kind of message that I have for people. Okay, you have a diagnosis of Alzheimer's disease. Now what? Well, there's a lot to do actually. And so we do, we treat the modifiable risk factors, all kinds of things through your primary care. We absolutely got to make sure sleep is good. These are all things in the facility you're in now. I guarantee you, if you have a resident or someone that's having trouble sleeping, I guarantee you there are non-medical interventions that you can provide the person on your own. And that's as simple as a little nighttime noise machine, a nighttime meditation, getting them an eye mask, getting them earplugs, getting them, all those kinds of things, blackout, shades. So you can't underestimate how powerful that is. If you help someone sleep that extra 30 minutes, for somebody with a dementia or even just the early signs of cognitive impairment for other reasons, even a traumatic brain injury, that's going to change their day. That's going to completely change how their day goes. So it's tempting to think like, oh my goodness, they need, give me some Ambien for this one. But, one thing I like to tell people is when I get patients to participate in we call cognitive behavioral therapy for insomnia. So it's a sub-CBT specialty that focuses on sleep hygiene essentially and behaviors around that. It's been really, I love doing it because I've never not been able to get a patient off of all of their sleep meds by doing that. And so that's proven to me over time that sleep meds are definitely meant to be temporary and are not necessary long-term with those interventions. That being said, It takes commitment. Not everybody can obviously participate in those interventions, but just keep in mind, every time we use a medication, if it's helping them go to sleep, it's probably going to have a side effect during the day as well. So these are all kind of things that we can help people feel better during the day and prevent behavioral emergencies. Delirium, which is intimately tied to behavior. So delirium is probably, as I was saying, people with cognitive changes, mostly due to dementia, neurodegeneration, are the number one cases where we see behavioral issues in residential facilities. Delirium is closely tied to that. Delirium is most often the driver of that behavioral issue. And so with the last session, we focused on delirium. And so we defined it as disturbance of attention and awareness. It's fluctuating, meaning you see it going up and down even the same day. They have some kind of thinking issue, whether it's memory or verbal ability. Something's not right. There isn't a pre-existing issue, but even if you have dementia, keep in mind you can still get delirium with dementia, but it's not their baseline. It's something that's changing from their baseline. They're obviously not. I mean, there's not another obvious reason like they're in a coma or just coming out. They hit their head really hard. And then there's this confusion assessment method, which you can also use, which is looking at attention, disorganized thinking, altered level of consciousness. And you can do things like doing this mini mental status or asking them spell world backwards, draw a clock. You can have them just do a couple things. And when you know the patient well, if that's suddenly different, that's going to be a big clue that something's wrong. And so with delirium, when we talked about triggers and outcomes, remember, risk factors in the long-term care facilities, dementia, number one risk factor, right? So someone who with underlying neurodegeneration, sometimes that delirium is the first window into knowing that they have dementia. So sometimes that's the big clue. It's like everything's fine. And then, they ended up in the hospital, they were dehydrated and they're delirious. And then there's an underlying Alzheimer's that I can see on the MRI. Polypharmacy, another reason we all have to be vigilant. Doesn't matter what our background or our training is. We all know what polypharmacy is. So when you see a patient that has a long medication list, you don't really have to even know what those medications are. If that's a long list, that's a risk, and we got to be careful. Restraint use. This is also a way to talk about prevention of behavioral emergencies. The more we use restraints, the more agitation and behavior we tend to see. So we've really, as a culture over the decades, we've really tried to move away from this. Of course, you have to keep in mind, patient safety and the safety of others around them always comes first. So there are occasions where you have to use them, but it turns out those restraints tend to almost never be needed more than a few minutes, which is really interesting. So gone are the days of, okay, they're acting up and then let's check on them tomorrow morning. Turns out you can check on them in 10 minutes, 20 minutes, 45 minutes. And in my situation, having done a lot of inpatient work where restraints are used, turns out, we were able to remove restraints vast majority of the time, the very first time we checked on them. So keep in mind, so patients that have to be physically restrained 5 or more times are more likely to have delirium. Underlying cause, let's treat that delirium, won't have the behavioral emergency. That's what we really want to get into a habit of thinking. The issue is not their behavior. The issue is the delirium, right? So if they're acting out of sorts, that's not the problem. The problem is why is their delirium? Dehydration, polypharmacy, sleep disorder, sleep apnea, things like that. You can see overall 68% of new long-term care facility patients have dementia. So you can see, it is literally impossible for any of us attending today not to see this. So there's no way to avoid this. That's how common we're talking. We'll just jump down here. These are some kind of down below here on the lower end is just some ways to help think about how to address delirium. Things like dehydration or just medical illness, UTIs, small things. They're not going to present like we talked about last time. They're not going to present like you or me listening, having a UTI and saying, "Ow, it hurts," when I go to the bathroom. Probably not going to hear that. We're probably going to hear confusion. "Oh, I'm seeing something," or "I'm seeing a little bunny running around the room." So we have to kind of tune in our brains into thinking, oh, wait a second, that might mean delirium. Let's ask or look into that. Let's do a quick, urine screen. No big deal. Oftentimes that's one of the more common causes, or subacute little pneumonia, something that maybe there's a little bit of cough, maybe not. A lot of our patients are immobilized, sedentary, so they're not necessarily coughing really well. So you always got to remember there's probably something going on medically that's just hidden and not what our
Hey, Reza.
typically look for. Yep.
Hey, sorry, just a couple questions. First, so would you? So it sounds like it makes sense as when people consider sort of doing the assessment, or before doing an intervention and doing kind of the assessment. It almost sounds like it makes sense to kind of go through a top 3 or top 5 list of most common reasons for delirium. It sounds like, right, there's dehydration. Mm-hmm. You were mentioning sort of dehydration was one of the top ones. What were the other? So sleep problems.
Medical.
What would you say were the top 3 to 5?
I would say infection is also always in the top 3. So whether that's a UTI or a lung infection or anything else, so infection is going to be up there. Polypharmacy is going to be, medication, secondary medication use is probably going to be the other big one. And then dementia, underlying dementia. Those are really
got it.
The biggest ones.
That's helpful. And sorry, the other 2 quick things, and I'll let you keep going. One is, one of the things I've been seeing with folks who are struggling with, I've been doing a lot of, I've mentioned this, working with vets who are older, who are struggling with a kind of combination of traumatic brain injury, possible, onset of dementia and PTSD. So I guess one of the things I was just thinking about, the overlap between kind of underlying psychiatric disorders and the impact on cognition and what that might look like when you overlay it on top of sort of dementia, right? And so it's kind of, it feels to me anyway, hard to untangle kind of the cognitive disorder and the mental health problem, because they kind of make each other worse. And then the other question I had for you is, does it make sense to prescribe like brain games, brain training games, things like Lumosity to help to kind of push people almost to exercise that muscle?
Mm-hmm. So the 2 points there. So Eric likes to give me a long list of questions and make it harder for me to answer. So I appreciate that, Eric.
You got it.
We're great partners. So to the point of the Lumosity piece, I always, it's interesting. It's kind of it's not controversial in the sense that, like people get angry about it, but it's controversial in the sense that the data is difficult. Lumosity is fine. I have mixed feelings about it because, they went overboard on their advertising years ago, and then they had to pay like a $7 million FCC fine because they were like, or maybe it was even FDA, because they were telling people, oh, we'll fix your member, like they were over advertising. So I'm a little more cautious. And they learned their lesson, they pay their fine, they're still around. There is Brain HQ is another app. That's a little more traditional in terms of like having scientists under it and having a lot of research studies, and there's a free version. So, but it's not that they don't help, it's that we haven't been able, so people in every study improve on the measures that they're measured, if that makes sense, meaning I test you on this test, you do the brain training, your test gets better. But we haven't been able to link the improvement to daily functioning. And so that's the challenge with those. So I still say to do it, because guess what? It's still something to do, and it's certainly not going to hurt, and hopefully it will help. But I wish I had that data. I wish I was seeing that daily functioning getting better. We just haven't seen that yet. But I'm not hopeless about it. I haven't given up on it. And I do tell people, and some people that are still using, I'm like, you know what? Go ahead and use it, because it still may help you remember names better. There are good training techniques. That being said, you can always, if you have access to one, speech therapy tends to be the ones to do cognitive training, hands-on, one-on-one, and they will actually do those functional things. So they'll like teach someone with early Alzheimer's how to use a calendar in a different way so that they actually remember and they don't forget their appointments, or how to remember to correctly fill their Mediset, or things like that. And this is for obviously early symptoms, but that fills that gap of getting a little more hands-on and under the functional improvements rather than just something on the computer. That was the answer to that. What was your first question, Eric? I already forgot.
It's okay. The other one was kind of the intersection of kind of cognitive disorders and mental health, or the impact of,
Yep. So I'm actually going to go over a study in a minute about behavioral emergencies, and it's going to touch on that. So that's a very good question. So I'm going to move along, and I'm going to get to that and tell you about it.
No, I know it's a good question, but I thought I'd just ask it. Hang on.
Oh, no. Yeah, I'll get you a good answer, I promise. Delirium approaches. So delirium is a medical emergency. So when you see someone have that quick change in their baseline cognition, it's something that you should communicate to your team. And again, we want to pause and think about what's causing it, not, immediately try to like mask it or, band-aid it, which, trust me, I've done before. It's very tempting because it can be scary sometimes when someone's delirious. It can be very nerve-wracking. We're not here to judge the past, or this is all about what do we do differently now. The resident may have poor judgment or difficulty. So it may be someone that usually is okay, but with delirium, you're going to have to step in and be a little more directive and a little more kind of directly impacting their safety and behavior. So you're going to have to really be thinking about that. They need to be reassessed frequently, mainly because it's going up and down. And if you have an infection, things are going to be changing rapidly. Here it is again, avoiding use of physical restraints and bed alarms. That turns out it tends to make delirium worse. So even though we're trying to focus on that behavior, that activity, we want to stop that. Turns out the best way is not to do that, which is interesting, right? So if it is delirium, we try to avoid that. Reorienting frequently is very helpful. Telling them where they are, who they are, what's going on. Remember down here, when a clock or a calendar or a telephone is absent from a patient's room, they're more likely to have disruptive behavior. So the more alertness you can provide for them, the better. Alona's laughing because she doesn't have a clock or a telephone or a calendar in her room, and she's always disruptive. So, all right, let's throw out the first poll question. This is hard balancing 10 sessions because now by session 6, the recap takes like half the time and I was blabbering for so long. So how many times in the last month have you witnessed a behavioral emergency? And I'm purposely not defining it yet, but how many times?
Can we put that one as put your response in chat?
Yeah, or feel free to yell out.
There was also a question earlier. Let's see, I'm trying to find it here. As a social worker, I have provided counseling to many nursing home residents about previous traumas in their lives, such as abuse, incarceration, divorce, poverty, etc. It helped them in terms of health, mental health, and behavior. Can you comment on the importance of asking residents about their past and social histories or subsequent conversations, which I always do, in order to determine if they want to talk about this? Dementia patients, they can't articulate.
Great question. I'll answer that. I think Dr. Seiss was about to make a comment too. But to that question, very good question. And it's always a balance. And as a social worker, you know this very well, better than me. Sometimes people want to talk about it. Sometimes it's upsetting for them. And so balancing how much you want to ask about. In the setting of dementia, that's why I rely so much on family history, caregivers, to get a clue into some of the things that would be triggers for them. You're absolutely right. So someone with dementia who had a very specific childhood experience, but may not be able to talk about it anymore, but still influencing their behavior by causing, agitation or irritability. Very good to know that. So I think it's always good to ask. I think that should be standard as a team. That's part of this multidisciplinary team. So you having that behavior, I really expect you as a social worker come and tell me as a provider and be like, make sure you don't bring this up because he's going to punch you in the face. And I'll say, thank you very much. So, it's extremely important. It might obviously not be like that kind of agitation, but even if it's bothering them enough to maybe they brings them to tears a little bit and I have no idea. It's absolutely the right thing to do. And it does impact them their whole life, even with dementia. So I hope that answers your question, but it's very important. And then Jill asked a great question. Untreated pain, absolute good trigger. It's not, we don't think of it as like the one of the most common triggers of dementia and delirium, but absolutely. So we like to rely on Tylenol, Advil, things that are non-narcotic to treat that. So absolutely. Sorry, Dr. Seiss, what were you going to say something?
I was trying to add some extra audio by counting in the number of behavioral emergencies I saw in the last
Nice.
month. And
Did
that's,
you,
of course, skewed, looks like hyperbole, but covering consult psychiatry, a big hospital, and inpatient psychiatry, puts
Yeah.
you right there front line.
Well, yeah, Dr. Seiss is the one that gets called to all the behavioral emergencies, so he's going to see a lot of them. Across the rest of the responses so far, I see, yeah, so some people have had more than 2 to 4 or several, but then a lot of people 1, and yeah, just a few people 0. So that's good. We want to keep it as close to 0 as possible. One other question before I jump into the study I want to show you. Do you normally feel that you have a good understanding of what caused the behavioral emergency? Yes or no question. So in those times you witnessed it, whether or not you were directly involved or it was even your, responsible, you didn't have responsibility over the patient, regardless, do you feel like you kind of think back and you say, okay, oh, it turned out that person had a UTI and that kind of stuff, or, someone said something about their childhood and brought up a really bad memory. Do you have a good understanding? And this is really helpful to, thank you, put in the chat, but I do want to hear from you guys, which I will try to make some time at the end so we can hear about this. So good, we're hearing yes a lot, so that's great. Sometimes, yeah, about half the time. So this is very interesting, right? Because people are saying, there are, sounds like a majority of times across everyone where they do have a good understanding. So that tells you, if I asked you that before that situation happened, you might not have said the exact same answer. And the point is that we all know a lot more than we think, because that time you spent getting to know the patient, getting to know the resident, it really informs that prevention strategy in terms of what to avoid. So getting into and please keep the responses coming, I appreciate it. The behavioral emergency definition. I kind of was looking around and seeing, obviously there's not one universal definition, but most commonly defined as a situation in which a client presents as being an imminent threat, risk of behaving in a way that could result in serious harm or death, or to self or others. So when we talk about behavioral emergency, that's what we really mean. The fact that it's emergency means if we don't do anything, there's a high enough concern that something bad's going to happen, whether that's harm to themselves or to someone else. And so that's what we consider an emergency. Now, sometimes it can be really hard to gauge what is an emergency, because sometimes someone might just like to do a lot of yelling and be really, really hostile, but historically they've never actually hurt themselves or others. So this is all about context, right? And knowing that patient and knowing their history, that's always going to be the most important thing. I have a patient with frontotemporal dementia who's getting older now. I've had several, but most recently that will say the most outrageous things and has set off alarms, has had police come, security. But I've got to know now, it's like, you know what, don't worry about it. And it is a risk. You never know, but it just turns out their filter's gone. They say things, but there's no behavior ever in line with what they say, even though, they've called and said, I'm going to bring a gun to my next appointment and kill the doctor. I've even had patients say that. And then when I confront them about it, they just laugh. They're like, oh, you shouldn't believe everything I say. They say, but that filter's gone. So you have to take it seriously, of course. Always. But you have to take the context of, oh, I've known this person a long time, and they like to just say things very dramatically. So that's a great, Marilyn, thanks for that example. We discovered the color green would trigger one of our ladies and found that it was from the war. The soldiers that came to our village wore green. Perfect example. Comes up all the time. You just reminded me, I think I shared one other time about one of my patients that was in an internment camp and who was Japanese in World War II. And same thing, still in her late 90s, still brings it up all the time. So this is very, very helpful. Now all of a sudden, think about not using the color green avoids restraints, medications, harm, all this stuff, right? And what a simple sort of intervention. And even if you can't always control it, even let's say color green shows up on the TV or something, still that arms you with an ability to do something about it, even if it's not fully prevented. Moving on, I want to just have a time to go over the study. So preventing a behavioral emergency, I just want to point out, we never want to challenge the validity of patients' fears and complaints. This takes multiple, it's not as easy as you think necessarily. It takes many forms, meaning, obviously I would hope that a lot of us here would not just go up to a patient and be like, oh, you're worried about COVID? That's stupid. We're not talking about the drastic scenarios. We're talking about, smaller, more subtle things, like maybe a patient says, oh man, I'm really worried about, something very, very small, like, my son, not visiting, we want to, oh, wow, like, why do you feel that way? Even though the son lives next door and comes every day. So invalidation can be very easy to do. I've done it a million times, and I've had to slap myself, across the head and think, oops, I just invalidated it. That was not the right move. So that, especially for someone that has cognitive impairment, that's prone to getting agitated, will just have more of an impact. Obviously, issuing threat, and again, I know most of us, or if not all of us, are not saying, oh, I'm going to do X, Y, Z. It's, oh, if you don't calm things down, I'm going to have to call security or whatever. Things like that tend to also not to be as helpful as we think. Sometimes that is helpful when you're talking to kids, right? But not as helpful when we're talking about older people with dementia and delirium. Speaking in a condescending manner and then deceiving, obviously trying to hide things. Again, none of these are meant to be judgmental. These are all things we will do out of desperation. I've done it, and so it's just being able to pause and recognize that. Now, I just want to spend a few minutes to really focus on, to drive the point home, on a study I found, which was really helpful. So this was a 1 year of data of all patients that came into this hospital. This was a non-psychiatric hospital. So you can see what was significant in terms of differences. There were 83 behavioral emergencies, as they termed, which meant they had to activate, the whole behavioral protocol, like a code, whatever. And you can see there was a total of 23,000 visits. So a lot of visits, not that many behavioral emergencies, but what was significant? Age was a significant variable. Sex turns out to be significant. The behavioral emergencies tend to happen much more often in men. And then, oops, sorry, scroll down here. And then let me move this out of the way. So things that impact cognition, I want to point out. So epilepsy was a significant predictor. Substance use impacting cognition, right? Not so much GI issues, not so much other medical issues, but traumatic brain injuries, cerebral vascular disease, stroke, those are all important. And then mental health, behavioral, neurodevelopmental disorders. What's interesting is substance use disorder was very high, anxiety and mood disorder were high, but then look at this, schizophrenia, things that a lot of the stigma, these things carry. We have people with chronic schizophrenia that we take care of, and people are like, oh my God, aren't they, aren't you worried they're going to hit? No, schizophrenia and things like those, chronic mental illness, they do not have any higher risk of harm than general population. And so there's a lot of stigma with that. So we have to constantly remind people that, no, that's actually not the case. It's things that cause cognitive impairment, like substance use or dementia. So that was one really good thing to remember. Also, here, risk of behavioral emergencies. So they stratified by sex and presence of a condition that caused cognitive impairment. All of a sudden, when you put those two things together, that's when you get the best predictor. And so in fact, a man with a cognitive impairment, so a man with the presence of cognitive impairment there, 13 to 23 more times likely to have a behavioral emergency. So those are the two strongest predictors, not schizophrenia, not cancer, not any of these kind of other things that we might sometimes think of. It was dementia or another cognitive issue when they have cognitive impairment. Now, being a woman, less so. Obviously, cognition, look at how much it bumped up for women too, from 2 to 18 and then 15 to 48 across men in terms of having behavioral emergency with and without cognitive impairment. So these were super helpful to see this. Jill. Where's Jill? You have to show your face. Where are you? Oh, there you are. I have to scroll over. So the moon phases, you making me answer this? Really? I'm just kidding. I get this asked a lot, actually. It's a really good question. I haven't come across it. It comes up a lot. I'll tell you right now, I don't dismiss it, and I'm not an unbeliever. so for what it's worth, but I haven't seen like an actual study yet, but that's pretty, and it's an interesting question. I do get that asked actually on a somewhat regular basis. I wish we should. Maybe we can all team up to do a study. I'll come out to Montana. We can all camp out and see what happens on a full moon.
Okay, well, you're on duty on the full moon night then.
Yeah, exactly. Yeah. That's the one that's actually, yeah, that's my on-call night of the year. I just do it,
Yep,
a
that's
few
the
times a
one.
year. Over here, just looking at scenarios. So this is all right in inpatient facilities, so relevant to long-term care, but other incident details. So when they looked at the behavioral emergencies, what were correlations that were highly predictive? So again, 6 p.m. to 6 a.m., much more common to have the behavioral issue during that time. Inpatient was the most common. Of course, the size of the inpatient floor is bigger, but that's the place where you're going to see the behavior and have more time for that to develop. When you're in an ICU, sure, it can happen, but that's often a lot easier to point to delirium when you're in an ICU. Reasons for activation of rapid response was agitation, combative behavior, acute confusion, aggression, and threat to leave AMA. Intervention. So this is where we have a big learning curve here. Look at these interventions, right? And this is no fault to this hospital. This is kind of what happens. But pharmacological management is almost always used, constant observation or mechanical restraints. What do we say? Those are exactly the things not to do. So why is this happening? Well, people are going to do the best they can in the situation they're in. So this is not to look at individuals. This is to look at systemically how we view things. If someone comes running out of the elevator screaming, it's pretty hard to pause and say, I wonder if they have a UTI, but that's where the multidisciplinary team comes in. And that's where we're in a position where a lot of these long-term care patients, we know them over time. So we know when things are changing. Inpatient, of course, in a hospital, different setting. Dr. Seiss is very familiar with this. But in a long-term care facility, that's why it's so important to know your patient's background, where they come from, what things can trigger them, and also being able to see when they change from their baseline. When you can pause and ask that question, address the underlying cause, that's how we prevent a behavioral emergency. We don't have to even get to the point of having to consider a restraint or hopefully not a medication. But again, one-time dose of something for an anxiety medication, not the end of the world. But we just don't want to make it a chronic thing. That tends to not help the long-term improvement of that patient. So last couple slides. I know we're running out of time. Again, just pointing out that the darker bars are the ones that had the behavioral issues. The lighter bars are not. So just pointing out substance use. That's Dr. Seiss's area of expertise. Huge predictor and has a big impact on the number of behavioral issues. Dementia, of course, we talked about, which goes hand in hand with delirium. Epilepsy, because that has a direct impact on your cognition. Stroke, cerebrovascular disease, also directly impacting traumatic brain injury, or any of the following. So you can see these were the most common. So not necessarily what we always expect. So just to sort of end, in a kind of collaborative sense, prevention is everything. Of course, we talk about management. Of course, we talk about intervention. We have to. We are on the front lines. We are going to have situations where we can't always, prevent it, or something is escalating just too fast. That's fine. That's not a failure. That's going to happen. This is all about taking those little steps, preventing one at a time. Even if we decrease that percentage of mechanical restraints by a couple percent, that's a big win. So, we have to remember, we're not going for all or nothing. We're going for little steps here. And so taking a pause, what is the impact in their cognition? And I kind of wanted to hear from anyone that's bold enough to jump in just in this last minute or so. Anyone been able to redirect or de-escalate successfully, and have, and like someone that put in the chat about the color green, that was a great example. Does anyone have any other examples? And please make sure to complete the evaluation. It's in the chat. Who wants to share something? Come on. Come on. Come on, guys, say something. It's the end of the day. Well, it's not the end of the day in Hawaii, sorry. Does anyone have a situation where they had a resident or someone they're proud of where they said, wow, I knew, or I was able to detect that there was some sudden change and I was able to figure out why that change happened?
I'm gonna pick one. How about if we pick somebody? Hang on.
Nice, pick someone.
See, out of all the people that answered,
We can all
gave a number. How about congratulations, Pamela Stanley. You're on. You gave the number 2 to behavioral emergencies. Come on, Pamela.
Tell us about one or both, and tell us about just describe it. You don't even have to have figured out exactly why it happened.
Pamela.
You can't find the mute button, huh? I've heard that excuse a million times.
So yeah, actually I couldn't. I was filling out the survey. So one of them is a particular patient of ours that just kind of went rogue and tried to hurt herself as well as to hurt the caregiver that was with her.
Mm-hmm.
And so it took several people to attempt to detain her from hurting herself as well as to prevent hurting anybody else. And we had to call and get orders for IM Haldol for her. So, that was not the desired outcome, in long-term care to have to sedate the resident, but that's what we ended up having to do to prevent injury to either the resident or the caregiver.
Was that one, Pamela, was that a case where that was out of the patient's character, or was that sort of something that had happened before, or was known?
No, it was not something that I had encountered. I understand that a year or so previously it had happened with this particular patient. The patient has Huntington's.
So something like Huntington's, where you have a rare neurological disorder, that's not necessarily a case where you're going to be able to prevent the way we hope. And so, antipsychotics are very commonly used in Huntington's disease because that a lot of times just out of the patient's control, which is unfortunate. A lot of psychiatric symptoms with Huntington's. And was there another case you said?
Actually, the other one was when I was in nursing school at API, there was a particular resident that was there, and the nursing instructor had suggested, actually the staff had said, yeah, we just don't really interact with him, this particular patient. We just don't, make eye contact with him, just kind of, stay out of his way, and he's fine. He's not any threat or any harm. And then the instructor had said, well, why don't you try to engage with him? And so I was like, well, okay, what can it hurt? Well, I did, I said, well, how was your day? And next thing I know, he just, lunges at me, and people come flying from everywhere, and they kind of drag him off. And I felt so horrible. And the instructor said afterwards, she said, I should never have told you to do that. She said, we should listen to the people that deal with these patients on a day-to-day basis because they know them best. So for me as a nursing student, that was really traumatic. And that was the first time I'd ever encountered, that kind of behavior where they had to drag a patient off. It felt really bad.
That is traumatic. And that's exactly the kind of situation where that happens. That happened to me in training as well, where, I maybe a little bit of, I was naive, but maybe I didn't know better. But, I remember approaching a patient who was in the VA. He had end-stage Parkinson's, would have really bad hallucinations, and would get agitated, but was generally very immobilized, was kind of frozen because of the really bad Parkinson's. But as some of you may know, with Parkinson's, you can get a burst of dopamine from a different part of the brain if you're terrified. So there are those case studies from nursing homes when there's a fire, all of a sudden the people with Parkinson's get up out of their wheelchairs and they run out just for a few seconds and then they fall over. So your brain does somehow, which is amazing, maintain the ability to do this fight or flight thing. And I thought, oh, I don't need any staff with me. It's gonna be fine. He's immobile. And then next thing I know, he's chasing me across the unit because he thought I was carrying a snake. which
Oh,
I was like,
wow.
I don't have a snake. I don't have a snake. He just kept yelling snake. And then I couldn't believe it. He kept up with me. I mean, it was amazing. But that was also very traumatic. But I think, yeah, the lesson learned there is, your proctor, you, me, we were trying to do the right thing, trying to like engage. But yeah, having the whole team's input of, okay, this is a history, and maybe going with somebody or controlled environment, so that, you never know, but you do have to control the risks. I was throwing in some, I purposely made this question a difficult one. And Pamela, thank you so much for sharing those 2 cases. I appreciate it.
Welcome.
Really appreciate it. Yeah, so to the point of even Pamela's experiences with her patients, but what is the best way to prevent a behavioral emergency? Know your patient well along with their needs. That is absolutely true. And I kind of, it was a trick question because C is also true. So I was purposely trying to make it hard for you guys to pick one. But yeah, taking a note in minor changes. So the better we know people, we're like, oh, wait a second, why are you kind of dehydrated? I think, because they're not going to tell you they're dehydrated. Eating less, they didn't get up and walk around today. They didn't get outside, they didn't sleep as well, et cetera. These are all ways that we can prevent behavioral emergencies. So I know I apologize. I have a tendency to go over time. So I don't want to keep you guys too long. I know it's busy days for everybody. Any questions, please reach out to me directly or to our lovely group here with Mount Pacific and let me know. Otherwise, we'll be reconvening in 2 weeks to talk about behavior a little more in depth and how to manage behavioral emergencies. Remember, fill out the survey in the chat, please, so we can keep track of everything.
Great. Well, thank you everybody for joining, and you all have a great rest of your day.
Thank you.